Thank you for watching the Momentum Men Ministry on Demand page. Today, you will hear a message from Dr. Victor Sims on colorectal cancer, preventable, treatable, and beatable. Now, prepare your hearts and minds for the scripture and the message for the day. Enjoy.
Reading the scripture this morning, we're coming from Proverbs 3, 5, and 6. Trust in the Lord with all your heart, and lean not on your own understanding. In all your ways, submit to him, and he will make your path straight.
Thank you, brothers. First, giving glory, honor to God, and honor to our pastor, and this great men's ministry. Thank you for the opportunity to come and speak to you guys again. It's always a privilege and a joy to come and talk to us when I can about health issues and get you all together. I know we've been bombarded with COVID issues and what's been going on with that. I definitely can answer questions if you guys have that at the end of this talk. But I want to focus on colorectal cancer today. One reason being that this is a disease that this has basically really ravaged our community as an African-American community. So, and also disproportionately causes more deaths in our population than it does others. And then secondly, there's been a major change in the screening criteria, and we will get to that as we get a little bit further in the talk. So today we're going to talk about colorectal cancer because it's preventable, it's treatable, and beatable. Next slide. So facts about colon cancer. It's the third most commonly diagnosed cancer in men and women. The first of which cancer that's the most commonly diagnosed is lung cancer in both men and women. The highest risk factor there being smoking. And then the second most diagnosed cancer in men is prostate cancer. The second most diagnosed cancer in women is breast cancer. And then colon cancer is right behind both of those in diagnosis. A second bullet point makes a striking observation that colorectal cancer is the second leading cause of cancer deaths in men and women across the board. So even though it's the third most commonly diagnosed cancer in both men and women, the second leading cause of death across the board, next to lung cancer. That third bullet point just says that the overall lifetime risk for developing cancer is 1 in 23 for men and 1 in 25 for women. Just think about that for a second. That is a high incidence and high prevalence in our day and age. Regular screening can reduce colon cancer deaths by 1/3. And let me say this is one of the few cancers where 95% of these cancers are totally preventable. And then we're gonna talk a little bit about why in a second. Next slide. So how do we develop cancer in the first place? What really happens at a cellular level? And cancer is basically the proliferation or the growth or multiplication of abnormal cells. Something happens to our cells, whether it's from the genes or there is something we come in contact with, a chemical or a substance that makes these cells lose their ability to stop growing or the signal to stop growing, and then there's overgrowth. And that's basically what happens when we have a cancer. Colorectal cancer is when these abnormal cells grow in the colon or the rectum. And then I want to be a little bit specific here. The cancer of the anus, which is more on the outside of the rectum, is classified separately from colon cancer. And that's significant because the cell types are different. The anus is the outside of the rectum, so there's more outside skin there. In the outside skin, the predominant cell type is squamous cell. And then we'll talk a little bit more about the types of cancers for colon and rectal cancer here in a second. But all colon cancers start as a small polyp. Most of those are non-cancerous growths. Less than 10% of those polyps develop into cancer, and it's a slow process, 10 to 20 years. And that's why the screening is so important, because even if you're waiting, 5 years, 3 years, 7 years, whatever your surveillance program is, if you're getting and seeing the doctor and getting screened regularly, you can catch those cancers and nip it in the bud catch those polyps and nip them in the bud before they become cancers or they develop into a bigger problem. So polyps are divided into categories based on their growth pattern. And the types most associated with development of colon cancer are adenomas, sessile serrated polyps, what we call traditional serrated adenomas, and then the least likely to cause cancer out of these types are called hyperplastic polyps. Next slide. So this is the stage, and you say, well, what happens? How does a little small polyp then become cancer? And again, we're talking about a process of 10 to 20 years. First, you just have a hyperproliferation, again, abnormal overgrowth of cells. Then you have what we call small adenomatous polyps. A small one is less than 1 centimeter in size. What's considered to be a fairly large adenomatous polyp is greater than 1 centimeter. From there, you can get what we call severe dysplasia. Again, that's when you turn from being benign to precancerous. Now you have some abnormal cells. If you would actually pluck that polyp and cut it into sections and put it under the microscope, you'll see now that you're starting to get some abnormal cell growth that is gone. So cell growth has kind of gone wild, and now it's looking abnormal. From there, you get what we call adenocarcinoma. Bigger polyp now has some invasive cancerous cells in it. And then from there, you start to get the stages of cancer. So you can see at the bottom of this slide where the stages of where that polyp is benign, and then when it crosses over and then becomes malignant. Again, this is a process over 10 to 20 years, so it's a slow process. So if we're getting screened, many times we can catch this before it becomes a bigger problem. Next slide. So I'm going to do a little brief kind of breakdown in layman's terms of what cancer stages look like. You hear sometimes people say, well, I have carcinoma or cancer in situ. And what that means is there is abnormal cancerous cell, but they haven't invaded the wall of the colon or the rectum. And when we say the wall of the colon and rectum, particularly we're talking about the muscle walls. They're kind of superficial cancers. Locally means that you've had some growth into the wall of the colon or the rectum, but it hasn't extended to the nearby tissues, the lymph nodes, the other organs. When you have regional invasion of a cancer at that stage, you've had invasion to nearby tissues or nearby lymph nodes. And lymph nodes are little glands in our body that are used to fight off infection and cancer. At a small cellular level, most of these little 1 or 2 cells, the lymphatic system helps get rid of those and kills those cells, as well as little infections. Once that gets bigger than a certain level, though, and out of control, the lymph nodes don't stop them. Now, then you have a distant spread. If you have distant spread, then that means that that cancer now has gone to other places outside of the local or regional invasion. And that's what we try to prevent. The importance of staging is the earlier that you can get to a cancer, the more likely you are to prevent death, and then also the more likely you are to prevent the mortality, the morbidity, or how bad the cancer is. Death is mortality, so we want to reduce mortality by screening. We also want to reduce morbidity, which means you pluck the polyps, get it out, you're done with it. Rather than if you get something like a regional, a local, regional, or distant spread, then you have to do more things to try to treat that cancer, control it, and you cause more problems to the patient. Next slide. So what are the risk factors for getting colon cancer? Unfortunately, this is a cancer that just increases as we get older. And the theory behind this is as you get older, your ability to kill the small little cancerous cells in your bodies is less effective, number one. Number two is that the ability of cells to stay in their lane and do what they're supposed to do, we start to lose a little bit of that as we get older. So the median age of diagnosis of colorectal cancer is 66 for men and 69 for women. Now, here's the other part I want to kind of focus in on a little bit. When you look at race and ethnicity, the highest incidence of colorectal cancer in our country is in African Americans and in Native Americans. Now, and part of that has to do with genetics, but a big part of it has to do with environment. The foods we eat, our activity level, exposure to carcinogens or things that would cause cancer are big in our community And we're going to talk a little bit more about that here in a second. Men have a 30% higher incidence rate than women. Family history plays a significant role. So to the point to where even if you have family members or direct family members that get colon cancer younger than 50, you start to screen the immediate family members 10 years earlier than when that family member got their cancer. And the reason for that is that it gives you the ability to catch those cancers earlier on people that are higher risk. Health conditions that predispose you to getting colon cancer include type 2 diabetes, people that have inflammatory bowel disease, and those are ulcerative colitis or Crohn's disease. And then certain genetic syndromes. There's what we call familial polyposis syndromes, where everybody in the family gets a lot of polyps. Those people are at increased risk for colon cancer. And they get their screenings faster, they get them earlier, and they get them more regularly. And then lifestyle factors are important. Tobacco use. We know that tobacco increases the risk of pretty much every major form of cancer that you can think about. And alcohol consumption. We're going to get a little bit into that. Lack of exercise. A diet that's low in fruit and vegetables. As you know, everything that we eat goes through and is processed in our gut, small bowel, and then the colon. For our diets that are really low in fiber and low in fruit and vegetables, those people are increased risk for getting colon cancer. And then diets that are really high in processed meats and red meats. Again, the processed things we think are increased exposure of items that would cause, or things that would cause cancers to cancer level to increase, are considered this. Next slide. So this slide emphasizes one thing, and that is that the risk for getting colon cancer goes up as we get older. And if you look, where you really see a significant jump is at that age between 45 and 49. That bar kind of in the middle of this chart, where you see a jump all the way up to like 33.1. And this is the number of colon cancer cases per 100,000 people in the US population. From there up, every year until you pass away, the rate of you getting colon cancer increases. And this slide is significant because when we start to really see the incidence go up, at first our screening test was to start at 50. And then they say, well, if you're African American, you're higher risk, let's start you at 45. That was probably about 10 years ago. This past year, the significant change has been now all of the cancer societies, the American Cancer of Gastroenterology, which are the stomach doctors, the American Cancer Society, they all agree now that we should, the National Cancer Societies all agree now that we should start screening everybody for colon cancer at age 45. And this is the reason why we start to see significant increases at that age. Also, we're starting to see more cancers that are in the right side of the colon. And we'll talk about why that's significant here in a second. Next slide. Again, we're going to emphasize the fact that African Americans are having higher incidences, having more mortality as well. The graphs on the left, the bar graphs, talk about incidence. How often do, and what's the rate at which people are getting these cancers per 100,000 people in the population. The bar to the far left at each of these graphs represent non-Hispanic Blacks, so African Americans. The next bar over to it is American Indian and Alaskan natives. That Kelly green color one in the middle is non-Hispanic whites. The solid black bar graph is Hispanic or Latinos. And then the last bar graph on the right is Asian Pacific Islanders. And you'll see in each one of those, when you combine men and women, then it breaks out to men and then breaks out to women. African Americans have the highest incidence. And then on the other side, on the right side of these graphs, you see we have the highest mortality, the highest death rate. And that's a concerning thing for us. And that's why we're emphasizing getting colon cancer screening early and in high risk groups, which includes African American patients. Next slide. So how do we know if we got colon cancer or not? And the big thing that's bold is that first bullet point. Early stages in colorectal cancer, when you want to catch it, you don't have any symptoms whatsoever. So many patients will come to me and say, well, Doc Sims, I feel good. I don't see no blood in my stool. I ain't having no belly pain, so I must not have cancer. Again, we talked about those polyps starting as little bitty small overgrowths that you wouldn't have any sensations or any idea that you have whatsoever. And at hitting those ages, when you started getting 45, 50, etc., that thing grows slowly over time. As that tumor grows, it can bleed, can start to block the intestine. So by the time you start having symptoms, which they include bleeding from the rectum, blood in the stool, dark or tarry stools or black stools, stomach pain, unexplained weight loss. And the other big one here is an anemia. Some people say for whatever reason, they're tired, they're fatigued, and have anemia and not even be aware of it. I know I had one patient, and this was a story that kind of stood with me. I had a 37-year-old gentleman, excellent shape, black guy that played basketball every weekend. He played like 3 or 4 hours on Saturday, played 3 or 4 hours on Sundays with his boys. All of a sudden, he couldn't keep up. I sense I'm short of breath. I just don't have the same stamina, and he looked pale to me. So we checked his lab, and he was anemic. And that was the first sign of him having his colorectal cancer. Turns out he had multiple family members that had colon cancer, but they never done really a family history. I had him go home. He tracked that all throughout his family and found out on his father's side there were significant numbers of people that had died from what was colorectal cancer. Never talked about it. It was something that the family kind of kept quiet or hidden. Oh, he died, and it was a cancer. I think it was this. But when he really did the research, multiple people in his family had died from colorectal cancer, and he didn't even know about it. He had an uncle that passed away when he was 50. This gentleman, actually, the uncle was in his 40s. This gentleman actually should have started getting screened when he was in his early 40s or his early 30s even, because of the age at which his second direct relative had gotten colon cancer. So had he been doing the screening protocol, it would have gotten caught early. I know you guys are familiar with Chadwick Boseman, the Black Panther character, the gentleman that played the Black Panther, actually died in his early 40s at 43 from colorectal cancer, was diagnosed at 37. Again, very early ages. And so we're starting to screen earlier and starting to look for signs and symptoms of colon cancer earlier. Next slide. So what are the screening guidelines? Again, a significant thing is the United States Preventive Task Force recommends now for adults that they start screening at 45, age 45 and up. That age used to be 50. And then about 10 years ago, they started to recommend in 45 for African-American patients. Now everybody's supposed to start at the age of 45. A second bullet point basically says adults 76 and older can talk to their doctor about whether or not they want to continue being screened. I don't stop screening people, and we don't even have the discussion about stopping until they turn 80. Why? Because the graph I showed you earlier showed that your risk of getting colon cancer actually continues to increase from the age of 40 until we pass, until the end of this life. So I continue screening until at least age 80, and then we have discussions about whether or not we're going to continue to do those colon screening tests. Screening tests can find those cancers early, and then that's when our treatment is most effective. Again, colon cancer, one of the very few cancers in which you're getting adequate screening. 95% of those cancers can be prevented. Next slide. So how do we screen? So we have several different methods, and I want to walk through this with you in particular. We have at-home kits. You see your doctors sometimes do what they call those two types of fecal occult blood tests, where they actually check the blood, check the stool for blood in the stool that you can't see. Now we have even a more advanced DNA stool test that checks for the actual DNA for cancer cells. And I know you guys have seen Cologuard, the little crazy commercial where you have the little square box walking around asking people about having to have their colon tested for cancer. And if you do choose the Cologuard, you can do that every 3 years as a screen. If you decide you're going to do just check the stool for blood, that has to happen every year. And then there's something called a flexible sigmoidoscopy. That's actually where they put a long tube with a camera in it and run around the lower 1/3 of the colon, the last 1/3 of the colon, looking for polyps. If you decide that route, you have to do it in combination with testing your stool. So you would test the stool every year, and you would do that flexible sigmoidoscopy. And that's how you would do that to look for it. Next slide. So I want to emphasize here, when it comes to colon cancer screening, the colonoscopy is the gold standard. If you get a colonoscopy done and your colonoscopy is normal, then you only need to be checked every 10 years. So the average risk of low risk individuals, once they've had that first colonoscopy and that colonoscopy was normal, they say we'll see you in 10 years. Why 10 years? Because we know if there's any polyps that start to grow, as we mentioned earlier, you have about 10 to 20 years before that's at any significant size. So in that method, the doctor puts that thin flexible tube with the light and camera on the end, and they do the entire colon. And there's a distinction between the gold standard colonoscopy and the flexible sigmoidoscopy. The flexible sigmoidoscopy only looks at the last third of the colon. The colonoscopy looks at the entire colon. So if you're going to have a tube inserted in your rectum and go around your colon, if you're like me, I want you to do the whole colon so I don't have to come back for 10 years. That second method is something called a CT colonography. If you're going to do that one, that frequency is every 5 years. So basically, you clean yourself out. They do a special CAT scan using special dyes, etc., to analyze your colon. And then the computer produces images to look for polyps and look for cancer. It is a good test, but not as good as a colonoscopy. So the frequency at which you would have to get a CT colonography done is every 5 years, as opposed to every 10 with the colonoscopy. Next slide. So I'm going to look a bit at anatomy. You say, so what actually happens? And you'll see at the bottom of this slide an endoscope. So they use a colonoscope. The tube is inserted in the colon, and we kind of go backwards is the way that your stool does. So you'll see the flexible, the sigmoidoscopy and sigmoid colon on the right side of this slide, the descending colon, the transverse colon goes across, and then it goes all the way over to the end of the colon, which is what we call the cecum. That little, look like a little worm sticking off at the end of the cecum is your appendix. All the little bitty stuff in the middle of this slide is your small intestine. So food comes in, goes down through the stomach, goes through the small intestine, it goes past the cecum into the ascending colon, the transverse colon, the descending colon, and then out the sigmoid colon. So when we do a colonoscope or do a colonoscopy, the tube goes in backwards. And again, a flexible sigmoidoscopy would stop in that sigmoid colon, so you would only get a third of the colon looked at. A full colonoscopy goes the entire colon, and that's what you want, a full colonoscopy if you're going to have the procedure done. Next slide. The colonoscopy, again, is the gold standard because it evaluates the entire colon. And the beauty of it is you can diagnose and treat polyps at the same time. When they see polyps, when they do the colonoscopy, they pluck them out. They send them off for sampling to see if they were cancerous or precancerous. But by removing the polyps, you actually provide the greatest decrease of deaths from colon cancer. So both the colonoscopy is both your screening test, prevention, and also treatment if they see polyps. Next slide. So I want to dispel some myths. Number one, colonoscopy is painful. The fact of the matter is that the procedure should not be painful. Prior to the actual procedure, patients are given a combination of narcotics and a sedative. So you have what they call conscious sedation. About 95% of the patients are asleep during the entire procedure. They wake up and the thing that they give you to sedate you, usually it's Versed, you don't even remember having the procedure done. It takes about 20 to 30 minutes, and then you can resume all your normal activities the next day. Next slide. So the second myth is that colonoscopy is a difficult procedure to prepare for, and it's not. Basically, you have to empty your stomach, but it shouldn't be a horrible experience. They give you a combination of things to drink. They put you on clear liquids, usually 24 hours before, or they give you a number of pills to take and some liquids to drink in order to clean you out. And the common complaint isn't about the time in the bathroom or the actual colonoscopy. It's usually about how much stuff people have to drink. And if you have difficulty drinking large volumes of fluid, what the GI doctor sometimes can do is give you an actual prep that has less volume of less fluid. The more effective ones, though, are large volumes of fluid. Why? Because it actually goes through the system and cleans you out. And then just remember, the cleaner your colon is, the better physician can detect your polyps, and which is, after all, the whole reason why you're doing Now, if you ask people that had the colonoscopy done, they'll tell you the worst part is the prep. And it probably is because you're drinking stuff and going to the restroom, getting cleaned out. The actual procedure itself, very simple, very quick. Next slide. The next myth is that it's embarrassing. Well, physicians realize that a colonoscopy is one of the most invasive tests that you can ever have done. Even just the thought about somebody putting a long tube in your rectum and go around your colon doesn't sound good. But we try to do everything possible to ensure that this is the most private, respectful, and modest experience for every patient. My patients will tell me, well, I don't want to do that. You know, I'll never have that done. That's a violation. Well, imagine how much invasive stuff you got to have done if you end up developing colon cancer. And people say, well, I just won't get treated. Well, once you can't have a bowel movement because this mass has gotten big enough or you're starting to have issues, you have to be treated. And then it's a miserable experience. So the screening test is the way to go. So physicians have performed thousands of these, and because they perform thousands of these, we know how to do it. And then this preventive tool is crucial to detect colorectal cancer early. The whole mission is to get in and get this done early. And once you get it done and you can detect any problems early, you can deal with those before they become a problem. Next slide. There could be complications. No procedures without complications, but there's a very low complication risk of colonoscopies. Again, we've done so many of these to where the risk is minimal. And fewer than 1 in 1,000, less than 0.1% of patients ever experience any type of complication. And complications would include even just pain. Usually what people will say is they have gas afterwards because they shoot air into the colon when they're doing the procedure so they can see and they can actually get to the polyps. But that's usually the biggest complaint that people have. They'll have gas for about a day, and then they'll be sleepy if they got anesthesia. And those are the things most people complain about. But think about it this way. Your chance of getting colorectal cancer is much higher. Again, 1 in 23 for men, 1 in 25 for women, compared to the process or the chance that you will actually have a complication having an actual colonoscopy done. Next slide. The myth is that a polyp means I have cancer. Most polyps are benign at first, but if left unchecked, they have the potential to develop into cancer. So polyps can be easily removed during the actual colonoscopy procedure, and that's why we like to do those screening colonoscopies. So not all polyps are precancerous. So just because you have a polyp does not mean you have cancer. Next slide. Colonoscopy is just a screening technique. Well, think about it again. Remember, the reason why the colonoscopy is the gold standard screening test because it's all in one. You can get screening to actually look for polyps, but if they see them, they can actually remove them and remove those small cancers during the procedure. So if the colonoscopy shows you've got polyps, the doctors will remove them there on the spot. By removing the polyps at that stage, it prevents many of those polyps from becoming cancer. So again, the colonoscopy is both screening, prevention, and treatment if they find small polyps during the procedure. Next slide. Why is it important to get in and start getting your colorectal cancer screening early? This is why. If you see both colon and rectal cancer, and we talked about local, regional, and distant spread, and the last row on this thing talks about all stages, the survival is very different. If you even screen and you see localized cancer there. Now, first of all, if you see polyps and they pluck them, your survival rate's 100%. But if they see localized even spread and you get in earlier, your survival is 90% if it's colon, 89% if it's rectal. If there's regional spread and you go through treatment, 71% if they see colon cancer, 71% if they see rectal cancer. And even if you have distant spread and they find it, about 14% colon cancer survival, 5-year survival, and about 15% rectal cancer survival. Overall, if you get diagnosed with a colon cancer at all stages, 63% of people survive. If it's rectal cancer, 67%. But again, the key is the earlier you find it, the better you're going to do, and then the less likely you are to die. So early diagnosis made during screening can be curative and also really help your chances of survival. Next slide. The virtual colonoscopy or the CT Colonography, people say, well, I want to do that. There are pros to it. It's a computer enhanced spiral CAT scan. It's non-invasive, no sedation. That's the pros. The cons are it requires bowel prep, just like you would to do a colonoscopy. There's more air entered into the bowel by rectal tube so that they can see. That can cause cramping. If you find polyps and you have a CT colonography done, you're still going to have a colonoscopy because they still got to go in there and get the polyps that they found. And then the availability is limited, and some insurance coverages are very limited. And then there is a little bit of some radiation exposure. So it's a nice test to do, but it is not the gold standard because the colonoscopy, again, can actually see, find those polyps, and then treat them all at one time. Next slide. What can I do to prevent colorectal cancer? 5 things you can do to decrease. Number 1, regular exercise. 150 minutes a week is 30 minutes a day, 5 days a week. Simple. Number 2, increase fiber and water, I would tell you also, in your diet. More fruits, more vegetables, more whole grains. I mean, this is common sense stuff that they've been teaching us since we were kids. The more natural and the less processed your foods, the better you are because your system is made to handle those things. Reduce the intakes of red meat and processed meats. Beef, hot dogs, sausage, salami, bacon. And so you can decrease those, increase more fresh fish if you're gonna have meat and fresh meats other than just red meat into your diet. Limit your alcohol consumption. I'll tell you, for men, if you drink modestly or moderately, you wanna limit your drink to 2 drinks a day. If you're a woman, you wanna limit it to 1 drink a day. Why? Because many studies have shown above those limits, you start to have problems with your health. Colon cancer being one of those. And then get screened for colon cancer. Again, somebody sent the question and just asked you a second ago, can you start earlier than 45? You can, depending on what's going on with your family. If you have high risk, if you're having issues whatsoever with your stomach, or you're having bowel changes, etc., you would start earlier. But for the average risk person, 45 is a nice, very efficient and adequate age at which to start getting colon cancer screening. Now, if you have family members that have colon cancer, depending on their age, you may start earlier than that 45 suggested age. Next slide. So in conclusion, screening decreases the rate of death from colon cancer, also decreases morbidity, all the issues that come around getting colon cancer. So it can lead to the removal of polyps before they become malignant, and it can diagnose early cancers that can be cured. That's the whole reason for colon cancer screening. And again, 95% of colon cancers could be prevented if we just got adequate screening. Next slide. And we need to do better as a country. If you look at this chart, I know it's kind of small, but you look at Texas, our screening rates for colorectal cancer, 63%. And it's some of the lowest in the country. People say, why is that? Access to healthcare is a big issue. People not wanting to get the procedure done. If you even look at people that have insurance, those numbers are about the same, 50 to 60%. And people say, why? Because people don't want to go through the process of having it done because of all the reasons we just talked about and the myths that we just dispelled. It's important that you get that colorectal cancer screening. So as a country, we have to do better. And again, it is still the 3rd leading cause of cancers in men and women, and the 2nd leading cause of cancer death in men and women in our country. Something that's 95% preventable. All you need to do is get the screening. Next slide. At Kelsey, we've done something called direct access colonoscopy. What that means is if you're relatively healthy, we eliminate 1 step. And usually what happens is you come in, you talk to the gastroenterologist, they go through a whole thing about your risk factors, get history from you, etc. And then they schedule the colonoscopy. So then you have 2 visits. You have a visit to do a screening, and you have another visit to actually get the colonoscopy done. If you don't have any major health issues, what the GI, the gastroenterology doctors at Kelsey have done is streamline and simplify that. Your primary care doctor does a referral. You call into our gastroenterologist. The nurses call you back, take a history over the phone. They send your prep medicines to your pharmacy. You set a date to get the test done. So you meet the actual gastroenterologist the day that you're going to get the procedure done. Number one, it cuts down on the number of visits you have, co-pays, etc., to the gastroenterologist, and then you go directly in and get your study done. We are respectful of people's time. If you're young or you're relatively healthy, that actual pre-procedure consultation can be done over the phone with the nurse. And then we send out the prep medications to your pharmacy. You get those prep medications in pharmacies, schedule your tests, and then do your actual cleansing and your process before you go get it done, and you go straight in and get your colonoscopy done.
Thank you for watching. If you would like to join one of our live sessions, then please go on Facebook, type in Momentum Men's Ministry, and like the Momentum Men's Ministry that has the gold M as its symbol. It will allow you to be able to get updated information daily or weekly about our live next session, as well as some encouraging information. So, join us every Saturday at 7:30 a.m. Central for the TCWW Momentum Men's Fellowship. Also, watch us on Facebook, Instagram, YouTube, or live.tcww.org for live worship each Sunday at 8 a.m., 10 a.m., and 12 p.m. Log on to the churchwithoutwalls.org for all church events, announcements, and giving. All links and information are found in the description below. Thank you for listening, and I pray you have a blessed day. In Jesus' name, amen.